The next speaker is Dr. Mahesh. He will be speaking about pearls in the management of submacular hemorrhage. Dr. Mahesh is the president of KSO, the Kerala Society of Ophthalmic Surgeons, and very senior retinal surgeon at Giridhar High Hospital, Kochi. Over to you, Dr. Mahesh.
Thank you, Bastin and KSOS for this session. I will talk a few points on the management of submacular hemorrhage. Submacular hemorrhage, there are two types. One is subretinal, under the retina, and one is sub-RP, under the retinal pigment epithelium. So both has implications, and there are different types of classification, small ones, medium ones, large ones, like that. And the natural history of submacular hemorrhage is always poor, because the iron in the blood is toxic to the photoreceptors. There will be shearing, there will be fibrin will be there, which will cause destruction of the RP and photoreceptors. So natural history is always poor. So once it bleeds, it has to be removed. So the damage to macula has to be avoided as early as possible. There are different types of management. One is called anti-VEGF alone. Lot of us do that. For example, small submacular hemorrhage that need not be displaced. You can just inject anti-VEGF, and already you can see some altered dehemoglobinized blood. So these cases you can just give anti-VEGF, because there is no role for displacement from the macula. It's a small one. So follow-up vision after 2 doses of anti-VEGF injection, it has it improved. The OCT has significant improvement. The infrared is showing some hyperreflectivity, so this patient improved to 612. There is another group where the blood is above the fovea or below the fovea, but it has to be treated. So here also you don't need to displace the blood, because if you put gas, it will go under the fovea. So there also we give anti-VEGF injections, and with injection gradually, with 2 or 3 monthly injections, it goes. Number 3, where we do just anti-VEGF, is peripheral, PEHCR, peripheral exudative hemorrhagic choroidal. This is a type of polypoidal choroidal vasculopathy, where you can get peripheral bleeds. Macula is not involved, so you don't have to displace the blood. Just inject, and gradually the right side photo shows patient has stabilized over time with a couple of injections. Number 4, already scarred CNVM or dehemoglobinized blood, you can just inject some anti-VEGF injection. So these are some of the post-injection. This is a picture, even though vision was not good. So this is another case, PEHCR, where there is a peripheral large hemorrhagic choroidal detachment. Here also we give anti-VEGF injections, and it improves. Now this is Paginax is brolucizumab, which has a smaller molecule and penetrates deeper into the subretinal area. It has slightly better advantage. Now the choice of the treatment, like I said, depends on duration, size, thickness, and economics. So we published in 2003 just gas injection for displacement of submacular hemorrhage in IGO in 2003. This was at that time TPA was not available, and later in 2007 we had one big series which was published in Retina, which is even now quoted in many articles. So we had a series of cases where just gas injection was given to displace the blood. These are some of the old pictures where we have displaced the blood with gas injection, and they all did quite well. And this is the pictures from that article. Advantage is very economical. You need only gas, very effective. Adverse events are less. Drawbacks are there. Need recent hemorrhage, fresh hemorrhage, thick hemorrhage. Pre-retinal sub-RP hemorrhages are not very good, and many of them result in breakthrough vitreous hemorrhage, needing vitrectomy following that. Now came the tissue plasminogen activator. It was quite expensive once upon a time, but now it is available freely with smaller content, and price is also less. So TPA is a drug used to liquefy the blood, and the standard of care now in a large submacular hemorrhage is intravitreal or subretinal TPA with gas. The rationale is this combination helps to liquefy the blood, and gas helps to displace the blood. So this is a case where there is a massive submacular hemorrhage, and this is the OCT. TPA intravitreal was given 50 microgram, followed by gas injection, and immediate post-op day 1 itself it has started displacing. This is another case in the macula and above. and this case had a TPA, intravitreal TPA with gas, and following that, the blood displaced, improving the vision to 6/9. That is not over. You have to do an ICG or angiogram, then see the polyp you can see in the upper arcade area, and thermal laser was given. But this is not the case for every, this is not the option for every case. Like this, if the large subretinal hemorrhage is there, like this, the only thing is surgery. So surgery is the last choice in many of these cases, and this was a case that I did just 2 weeks back. Massive subretinal hemorrhage and with breakthrough vitreous hemorrhage. So what we do is induce retinal detachment. This was mostly liquefied blood, so it is coming very nicely with suction. So then inject little fluid under the retina, and then again dissolve the, displace the blood. I made 2 retinotomy, and through that injected fluid, and then 3-4 times this was repeated. Finally the whole, this is again inducing retinal detachment. So if the blood is thick, you can inject TPA like this under the retina, wait for some time, liquefy the blood, and remove. Same procedure can be done. So after complete evacuation, as much as possible, silicone oil I put because I am firm believer of silicone oil, and laser was done around the retinotomies. So this is immediate post-op. After 1 week, that massive hemorrhage has gone, and in fact the source of hemorrhage was, there is a large RP rib below infratemporally, so that is the source. So take home messages are small submacular hemorrhage, anti-VEGF, and preferably one of these new generation brolucizumab or something, that is enough. Fresh subretinal, subretinal, I am again telling sub, not sub-RP, TPA with gas is a standard. In cases where TPA is not available, do gas alone with displacement. Massive subretinal hemorrhage, vitrectomy with or without subretinal TPA. So this is a standard of care in managing the subretinal hemorrhage. Why we do all these things? Because if you don't do, this is a standard endpoint with a scar and hand counting finger eccentric vision. Thank you.
Thank you, Mahesh, for that excellent presentation. Any questions?
Immediate. That was the old, the subretinal hemorrhage, it comes, you have to treat immediately, as early as possible.
Will you have to repeat the injections, anti-VEGF?
Anti-VEGF injection, like the first few cases, only anti-VEGF was given, that you have to repeat monthly only, not beyond, not earlier. So that is only a small group. But nowadays you don't wait if there is a large submacular hemorrhage. Immediately do one of these. Lot of people inject TPA subretinally and just put gas. That is also another option. They don't remove completely, then to displace. There is a subretinal cannula is there, 40, 41 months.
Okay, next
I
we
think,
have...
Ramesh has experience in, you have done in a lot of cases there. This anti-VEGF, a lot of cases are there. Yeah. This in those cases we do fluorescent ICG angiogram and see some polyps are there. We treat that with the so it's a combination. Yeah, some people do come back with new polyps and BVN from different areas.